Hello, I am Jan Vissers of Erasmus University, Rotterdam. I will present to you the main features and findings of the stroke case as part of managed outcomes. Stroke is an important challenge for EU healthcare systems. It's one of the most occurring causes of death. It places a large burden on systems, patients and families. We believe that the solution of this can come from a better alignment of services in the regional network of providers. The large differences in outcomes in different countries can be explained to a considerable extent in the way we organize the processes for patients. We investigated 6 case instances in 6 countries, shown on the slide. The case instances differ in type and size of hospital involved and the number of strokes. We demarcated our study to concentrate on the diagnosis, treatment and rehabilitation in the hospital, excluding primary and secondary prevention, further rehabilitation and chronic care. We organized the results of our study around the components of our managed outcomes approach. We will show some results: incidence of stroke, cost of stroke services, and also show the relationship between cost and outcomes. First, some information on the incidence of stroke. This varies widely between the case instances. We see high levels of incidence in Keski, Suomi and Valencia, followed by Tilburg and Brighton, and then the low levels of incidence in Erlangen and Athens. Also, the costs vary widely between case instances. Here are shown the results of the costs of ischemic stroke services from the onset of the stroke to the discharge from the hospital. The costs are broken down to diagnosis, treatment and rehabilitation. The highest total costs are in Keski, Suomi and Athens. The lowest costs are in Valencia. In this graph, we relate costs to outcomes by calculating relative efficiency measures. The results show that we see a cluster of case instances showing better performance on clinical outcomes as well as perceived outcomes by users. We have therefore identified this as a good practice on this performance. In the same way, we identified a cluster of case instances with a good practice in providing fast speed in the hyperacute phase and good outcomes in clinical terms and as perceived by the users. As key findings of this study, we identified differences in the production system and differences in the regional embedding of stroke services. In some cases, all patients are admitted to the stroke unit and then stay for a number of days in the neurology ward. In other cases, patients are triaged at the emergency department and then part of them is admitted to the stroke unit and the other part goes directly to a medical ward. We also see that hemorrhagic stroke patients are not always operated in the same hospital. It is of course interesting to see whether this makes a difference in outcomes. We see also case instances with a limited scope of services versus a broad scope. We see case instances with a light structure of collaboration versus a structure serving as a platform for evaluation and improvement of stroke services. Here we summarize a few main findings on identifying good practices as shown before. We see cost related to health outcomes and speed related to health outcomes. In both cases were we able to identify good practices. To conclude, some remarks on how managed outcomes can contribute to better stroke services and some recommendations for further improvement of our approach. The multi-perspective view offered by managed outcomes helps to provide a rich picture of the performance of the stroke services. Adoption of this approach in stroke service management can provide support for systemic and systematic improvement. Our approach can be further improved by investigating the gaps between performance as measured in our study and clinical guidelines. This would require a bridge between operations management approach and the medical perspective on stroke services. Thank you very much for your attention.